Good evening. Welcome, guys, to the second edition of our Special Operation Forces Health webinar series. As usual, huge shout out to our sponsors. These are great businesses that are looking out for the entire community. They all ponied up cash. They all were able to make this happen. Zoom webinars are not cheap, and we want to make sure that this is free information to get out to all our SOF personnel and Reg Force as well. Before we get any further, I think it's important that we remember that we use operator syndrome as a framework. So we're able to not get upset if you're not a special forces guy, but you've had traumatic brain injury, like a lot of Reg Force dudes did, especially during the GWAT. And believe it or not, a high percentage of TBIs and brain injuries come from training. So don't get upset that it's called operator syndrome. Think of it, of how you can use it to be able to match the patterns that Dr. Chris Frueh and his colleagues have found. And then from there, figure out what's your next step of recovery and how you can address it. When I look at the framework and I apply it to myself after 15 years before I got out medically, and I look at the injuries that I sustained during that time, it's wild. Not only that, but the pace of work that entire time, which is called allostatic load, was significant. When I first joined the military, I was deployed to Afghanistan 18 months later, from basic training to being in Afghanistan, where I learned what war was really like, where there were so many injuries, so many casualties, so many ramp ceremonies. And I got to feel it for myself. I took a IED to my face, and that started the waterfall of injuries for the rest of my career. We're talking about shrapnel removal in Afghanistan, multiple concussions, Lis Franck injury in my foot. I had hand surgery, shoulder surgery, knee surgery. My teeth are ground down, and I've broken multiple of them. I've had a partially detached retina that took 3 surgeries to get me back, and that's left me about 30 to 40% blind. Fractured sacrum, and I have a loose bone fragment in my elbow for the last 2 years. Those injuries just themselves, we can look at the psychological aspect of that, and what do you think that means to someone that was a special forces guy and did all these things, and now I'm in graphic design. I'm sitting in my basement right now, and I'm broken. I sit in a freezer for 4 minutes a day filled with water, hoping that it'll help me get better. And the psychological aspect of it, of losing not only that person before, which I'm good with, but it's just like, oh no, now I need to figure out what is going on with me as a whole, not just my mind and my spirit, because I've done a lot of work on it. But I look at operator syndrome, and it's very easy to go down, to use the framework and see where I'm at now, and look back and reflect on how I was acting, why I was acting that way. Maybe there's more to it than just like the big paint swipe of PTSD. He's got PTSD. Maybe there's more things to that, dude. For real. So we have people like Dr. Chris Frueh and his colleagues that dove deep into operator syndrome. Hashtag buy his book, comes out today. And him and his colleagues put some framework to it and gave us some simple solutions and ways that you as a veteran, or you as the operator, or you as the SWAT guy, whatever, can now go back to your primary care physician, your nurse practitioner, whoever, and you can action some of these treatments. All right, guys, that's enough of me speaking. Now let me introduce you to the author of the newly released book on operator syndrome, Dr. Chris Frueh.
Hey, everybody, Chris Frueh. I am a clinical psychologist. I got my PhD in 1992. So I've had 30 plus years of working with veterans and military and private defense contractors and special operators. Just a little bit about my pre-degree background. I am the son of a Vietnam veteran. My father was Air Force. He was a doc. doctor in Vietnam with the Air Force. And my great grandfather, who I knew very well until he passed away, I was 14 when he died, was a veteran of the Spanish American War. In 1898, he was at the Battle of San Juan Hill. So he was one of my early heroes in childhood. So I wanted to work with veterans when I went to graduate school. That was my goal, my purpose, and my mission. I spent from 91 to 2006, I worked in the US VA system as a clinician and then as a researcher and an educator at the Medical University of South Carolina and the VA there in Charleston. I've been at the University of Hawaii, where I teach college students since 2006, but I've also had quite a bit of commuting for part-time work in Houston at First Baylor College of Medicine and then the University of Texas Medical School there. So I've got all the academic shit and publications and grants and all that stuff. But my real passion and the focus of my work for about a decade now has been working with special operators. And so I kind of like to tell this story just because it kind of leads into, I think, kind of my thought process and kind of my own learning curve, which has been really steep over the last 10 years. I'm still learning. So it seems like every year I get a new kind of eureka moment and I'm like, oh, I wish I'd known this, 3 years ago so I could have helped those, other people with this. I had some friends who were freshly out of the military service about a decade ago, and in just spending time with them and talking with them, word kind of got around and got spread, and so pretty soon there was a handful of guys who I started meeting with. Several of them had been Navy SEALs, and a couple of them had been Army Special Forces. One of them came to me and said, and we were just over a beer or a cup of coffee, I don't remember exactly, but it was very informal, was his words to me were, I just don't feel right. I look in the mirror and I don't recognize myself anymore. I don't feel like the same person, but I couldn't even explain what's wrong with me. And that was essentially my introduction to what I now view as operator syndrome. At the time, I was a PTSD PTSD expert. And so kind of started from the framework of let's explore this. Let's kind of see if there's a reaction to trauma. And, clearly my friend was depressed and anxious, but he also was talking about his body didn't look the same. His face had changed, the shape of his face, the shape of his neck. His body mass was different from how it had been 2 or 3 years previously. I think at that time, he'd been out of the service for about a year. And he'd been at development group. So this was a very highly accomplished, very highly decorated. He'd been on a lot of the missions that movies have now been made out of. So we start talking, we're having these conversations, and pretty quickly I kind of tune in and I'm just like, this friend of mine, he doesn't have PTSD. That's not his problem. It's something else. And now I'm out of my league. I'm in over my head and trying to figure out what is going on. So just through trial and error, let's get a blood test. Let's get a sleep study. Come to find out, he's got low testosterone. 37-year-old man, this stud with low testosterone, that I didn't even understand that. It didn't make sense to me. And I probably at the time, I just kind of wrote it off as sort of an unusual thing and, a one-off kind of deal. But then we started testing the other guys that I knew, and they all had low testosterone, and they all had obstructive sleep apnea that we would find on in a sleep study. So I'm going to pause and just give you two pieces of advice right here, practical advice. If you have not already done so, get a blood test and have your hormones checked. Get a sleep study and see if you have sleep apnea or restless leg syndrome. Both of those really jack up your sleep. And from a healing and recovery and longevity and performance perspective, sleep is really kind of your best friend. sleep is what you want to, optimal quality sleep, both quantity and quality, is really, really important for everything that we're going to be talking about here tonight. So over the course of a lot of conversations, and pretty soon as the guys I was friends with started to do better and feel better, some of their friends, they started introducing me to their friends and then the friends of their friends. And so fast forward to today, I've talked with and worked directly with probably about 250 to 300 operators from all branches of the US military, a few Israeli, special operations, a small number of Canadian SOF, and I saw 19 was one of the funders here, so I have some connections to 19. I've also done a lot of work with firefighters and a little bit of work with law enforcement. So, as Gordo said, I want to be, I want to kind of make the point early on that what I call operator syndrome absolutely has relevance as a framework for many other people in dangerous professions, in warrior and protective professions. So law enforcement, firefighters. Had a conversation today at the barber shop. I got all cleaned up for this event, and my barber was telling me about his brother who was served in an Army artillery unit, and he's got a horrible TBI that nobody understands. So while I was getting my hair cut today, I was just kind of ticking down the list with him and giving him some of the same suggestions that I'm going to talk about here tonight. So what is operator syndrome? And so what I want to say is a few things to preface this. Operator syndrome is not a diagnosis, it's a framework for understanding the ways in which multiple injuries of different systems in the body start to affect each other. And so we're talking about interrelated medical problems that become psychological problems, that become social problems and challenges. And so I sometimes use the word whole systems. I don't like the word, I don't use the word holistic too often because it has some different connotations, not that they're bad connotations, but just different connotations. So I like to think of whole systems. And that means all the systems in your body, nervous system, respiratory system, skeletal, muscular, circulatory, endocrine system, and so on. And then we have the social system. So our marriages, our families, our units, our professional circles, at transition, we have different new systems that we become a part of. We have the healthcare systems that are around us. So let's be mindful. We're going to take a whole systems approach here to thinking about the types of injuries. This is really just comes down to pattern recognition. I mentioned that I've talked with and worked with probably about 250 operators very directly myself. I've also done another 270 estimate of evaluations of private defense contractors. So you can think those typically are like Blackwater shooters or our interpreters, our foreign interpreters in Afghanistan and Iraq. So all told about 500 people. And then I've worked with a number of foundations. So I do a lot of advising on the health side for several foundations. So I'm not directly talking to their guys, their people, but they are, and the feedback and information there is coming back to me. So I've become very confident that our healthcare system, our medical systems, and on the US side, that's the VA and the Department of Defense, have failed the entire generation of the global war on terror veterans and probably prior generations of soldiers going all the way back to World War I. We have, in our greater wisdom or arrogance, as I really think of it, we have a couple of easy buttons that we tap. So historically, still today, not historically, but since 1980 through present time, a soldier or a law enforcement or firefighter coming into a medical clinic saying something's wrong with me, usually that red easy button of PTSD is going to be hit. Oh, you were a soldier, boom, easy button. PTSD. And we're done. You got PTSD and we're done. Good luck to you. Here's a bucket full of medications. Maybe there's a therapist you can talk to once a month or so. Unfortunately, those therapists may not be culturally competent, may not know much about the war, may not know anything about special operations, and may not even have a sense that special and conventional operations have different roles, different training, different deployment experiences, and so on. So there's just so much ignorance out there, and that arrogance of thinking it's all PTSD. I've become almost, I won't say embarrassed, but for myself, but I am embarrassed for the field of psychology over much of what we've become. So if it's not PTSD, what is it? So operator syndrome, and I'm gonna pull up a couple of screen shares here. So this one first, you can see this. So this is a paper published in 2020. So it's literally 4 years old now. It's a research study that we published in the International Journal of Psychiatry and Medicine. And you can see the title, Operator Syndrome, a unique constellation of medical and behavioral healthcare needs of military special operation forces. I've got some phenomenal co-authors. I won't highlight all of them, but maybe a couple. Karen Kelly is a research physiologist who works with Marines and Navy SEALs in Coronado. And Morgan Luttrell, name may be familiar to some of you. He's the twin brother of Marcus. Morgan was a Navy SEAL. At the time we wrote this, he was a doctoral student at University of Texas, Dallas program, and he was studying neurosciences. He was working on a PhD in neurosciences. Subsequently to that, he didn't finish it, but he is currently in U.S. Congress now. He got elected to Congress. So this is the paper, and I'm not going to really put it up here, but I want to show you that it's a really easy paper to read. If you want a very quick opportunity just to learn more about this, I wrote this as we wrote this intending for it to be something that operators and their families could read and understand and make sense of. And part of the way I encourage people to use this, take it to your doctors, educate your own doctors, because they don't know, they don't understand this perspective. And you can see it's short. There's the beautiful picture that one of my colleagues put together. But it's a short article. It's easy to read, and it is literally just descriptive. And after it got published, I've since it's been published in the last 4 years, I've literally received hundreds of emails from operators, soldiers, active duty, retired, separated, firefighters, law enforcement, people from all over the world who've read it and said, "I read this and it's me." So, in a way, that's validation, and it's a form of validation. All right, let's get real specific here. Oh, I want to close that out. Bear with me. I'm an older guy, and technology still befuddles me sometimes. Okay, so this is the operator syndrome scale. This is in the public sphere, so anybody can download this from my website, chrisfrueh.com, or you can email me and get it, or Gordo's going to have it so he can share it around. I'm going to put it up here as an educational tool here tonight. You can kind of think to yourself as we're going through it that so the idea of this, and it can be used in a variety of ways, but it's really just a very short, sweet, and simple way of just beginning to get a snapshot of maybe some things that are going on for you. Operators can complete this for themselves. So none, mild, moderate, severe, but these are the domains that matter. Traumatic brain injury. And after I get to the bottom of this list, I'm going to go back up to traumatic brain injury, because I think that is one of the most important pieces of this. So much flows out of a traumatic brain injury. So many of these other conditions are either caused by or worsened by TBI. So TBI, sleep disturbance, which is insomnia, but oftentimes it's also sleep apnea. I think obstructive sleep apnea is present in probably about 80% of the operators I work with. Logically, that wouldn't have made any sense to me a decade ago. I wouldn't have predicted it. It surprised me. And brain injury and the high op tempo and the chronic sleep deprivation of the career. Endocrine dysfunction, that's hormones. Hormones are dysregulated. That's another thing that I think of the TBI, the pituitary gland, which is the master gland of all of our hormones, is in the brain. So brain injury. And remember, blast waves have a shearing effect. They go through the brain. So it's not just the things on the edges of the brain that are affected. It's everything even on the deep interior of our brains. Low testosterone seems to be the signature injury of our hormone system. I would estimate that um,
Dang. I think he's frozen, guys. If you want to throw it in the question and answer thing box and tell me if he's frozen. Oh God. No. Okay. It's all on me, Gord. You can do this. He's probably just gonna jump back in. Um, yes.
I'm back.
Yes.
I'm
I thought
back.
I could take it home for us. I thought I could sell you a couple bucks, man. Thank God you're back.
I'm
Okay.
back. Sorry about that, everybody. I don't know what happened. Um, Probably a connectivity issue at my end. So um, we're going to pick right up where I left off. Low testosterone is really common. For a man with low testosterone, that man is going to appear to be depressed. He's going to be irritable. He's not going to be sleeping very well. So he's going to have insomnia, which enhances the fatigue. He's going to be anxious. He's not going to have much motivation for anything. Working out is going to be hard. His body mass composition is going to start to change. Obviously, his libido and sexual functioning is going to maybe be altogether tanked or at least damaged significantly. And there are other things. Testosterone is really, really important for a man. One of the things I hear over and over again is guys are told you're in the normal range. But when I look at the numbers, and I'm not an endocrinologist, so it's not really my ability to be influential, but when I look at the numbers, I often see people who are at the very bottom of the so-called normal range. And part of the problem is operators and soldiers and responders are being compared to general population. So to tell a guy, well, you're 310 and our cutoff is 300, and that's okay for general population. But what are we benchmarking that on for operators? Operators were never general population. And I have the same problem, by the way, with cognitive functioning and intellectual functioning. Um, so we have a medical problem with how doctors, how medicine benchmarks, comparison. Okay. Number four, chronic pain, orthopedic problems. I mean, Gordo gave a really nice illustration. I know guys that have had 10 surgeries, 10 orthopedic surgeries or more. Very close friend of mine who was a retired Navy SEAL he had 20 surgeries, 20 orthopedic surgeries. And every surgery is a risk. We can call something routine, but when you're putting somebody under general anesthesia, there are risks. And my friend, who was 42, had a perfectly successful knee surgery, except he died a week later of blood clots. And his docs had not really been paying attention is part of my anger, but also just that many surgeries at some point, the more times you roll the dice, the more op times, the more chances you have of not coming up with the right numbers. The headaches are often debilitating. Those can be caused by TBI. They can be caused by other things. Chronic pain, even without a history of surgeries. I mean, the amount of mileage on the joints in the body is massive. The wear and tear, just the repetitive stress injuries of jumping, diving, rucking, rappelling, climbing, etc., are just massive. And you guys know this. A typical thing I hear is I say to guys, tell me what hurts, and it's everything. Everything hurts. Every joint hurts. And chronic pain is just a bitch. With chronic pain, you're not going to sleep well. You're often not going to be comfortable. It affects mood, it affects relationships, it affects quality of life. And this is something that we as a medical society, we've not done enough. For you guys, from what I've seen, is the chronic pain just gets ignored, almost virtually ignored. And a lot of you guys are your own worst enemies because you're tough and you suck it up and you don't want to raise your hand. So a lot of pain just doesn't even get reported. Okay, and I'm going to come back to the pain because I've got some lifestyle ideas, such as using variable resistance bands instead of free weights or body weight calisthenics. Bands are your friend. Bands work, and I'm not talking about the little hollow tube bands. I'm talking about the big, thick, uh, masculine bands that come with a bar and a plate that you thread it under. Those will You can stay dangerous with those. I've actually bulked up in the last 3 years using only bands. I'm 60 years old. I bulked up using bands at my age, which was a little bit surprising to me. Also, all my joint pain went away gradually. Not that I've never been a tactical athlete, but I did have chronic pain from a variety of sources. Um, Bands are good for your joints because they work with your strength curve instead of against it. And
That makes
explain.
sense. I've
I
kind of
can,
been I've been relegated to the bands just because I've had it was like bone and uh cartilage. They think that's the last thing. I talked to the lady today this morning. I was at the hospital talking to the doctor, and she said that all they can do is flush it out, and hopefully that works. And if it doesn't, then that's the way it is. But bands are like the only thing that can keep me going for some sort of strength. And then the pool. Like if you're injured, go to the pool. That's like
pools are good.
it's the
Pools are
only
good.
that's the thing for me. The pool just lets everything go back to normal.
Yeah, pools are good. Bands are good. Okay, so we got now we're down to number five, and I'm going to run through some of this quickly. So pretty common to see just one great big ball of unhappiness, depression, anxiety, anger, hypervigilance, which is a behavioral adaptation to danger, but it can become essentially an instinctive reflex. PTSD, and addiction and substance abuse, and these all kind of go together. I don't typically see what would be considered to be prototypical PTSD, which has the fear reactivity and the avoidance of things that might be reminders of military service. I don't see much of that, which is why I don't think PTSD is really the right answer to explain or describe what operators experience. I'm not saying it's not there, and certainly there are many symptoms of it there, um, but it's not a primary concern. Addiction, and then we can get into there are impairments to all the perceptual systems, hearing, vision, and balance, and probably others, but those are the big three. Get those checked. Hearing and vision. We don't have treatments for tinnitus, the ringing in the ears, but there are strategies one can use, such as just having white noise or playing a fan in the bed, having a fan running in the bedroom when you're sleeping. Then we have cognitive impairments. And cognitive impairments to concentration, sustained attention, memory, staying organized, impulsivity are often problems. And these cognitive impairments are easily uh, caused by TBI, but they're also caused by depression and anxiety. They're also caused by chronic pain. They're also caused by low testosterone. So there's a lot of things that are burdening and impairing the ability to think clearly. And with the TBI, it's harder to learn new things, which especially stinks because when you leave the service, you have to learn new things. You have to learn how to try to fit into a different world. Marital family concerns. I have just so much empathy for the children and the spouses and the girlfriends of operators because they go through it too. They're right there. They are suffering in their own ways, and they're suffering along with the operator or the responder. One thing that a lot of civilians don't know is that spouses and family members of operators have a certain level of isolation from the rest of the world because the rest of the world doesn't understand what their partner does in the military. They don't understand how they train. They don't understand what they do, when and where they do it. And oftentimes spouses can't even talk about, because they can't even talk with their friends and their neighbors about what their husband does or where their husband is and what he's doing. Intimacy concerns. So both emotional and sexual, and they go together, but they're also kind of separate. I mean, the sexual could just be very much a physiological problem with the testosterone, but sexual functioning also is affected by depression, TBI, chronic pain. See what I mean by when I say these things are all interrelated? They're interlocking. They go together. They cause each other. They worsen each other. Now, there is good news, which we'll come to, because you can treat one, which then creates a virtuous cycle instead of a vicious cycle. Treat your sleep, get your sleep dialed in, you're going to start to get benefits everywhere else. And that's just for example. Emotional intimacy is also a special concern. Very common for operators to describe just a simple loss of empathy. How do I relate to other people? Is that emotional connection there? And I think the loss of empathy and the habituation to suffering is really powerful because many spouses will say, I don't feel like many wives will say, I don't think my husband loves me. He's so cold. He seems so unaffected when I tell him I'm sad or I'm suffering. Doesn't understand that different people in society, including their own children, are bothered by many things. So it isn't that operators want to be hard. It isn't that they want to be ruthless and uncaring, but there is this, and I put it down to habituation. You are exposed to death often enough, injury often enough, hard situations often enough. It becomes harder to have empathy for the problems that people have. I experience a little of this myself, and I'll explain what I mean by that. I teach undergraduate students, and they often come to me with stories about how stressful their lives are and how much trouble they're having in class because they're stressed out or they're grieving something or they're sad and depressed. And I'm looking at what they're upset about. And I'm going, what's wrong with you? That's nothing. Why would you be so bothered by, something so small and irrelevant as that? And then I have to step back and remember that my perspective of what amounts to or what is a significant stressor isn't the same for everybody. Obviously, we have military to civilian transition difficulties. Gordo talked about that a little bit. I don't know how you guys do it. If I thought about somebody coming in and saying, "Okay, Chris, your time as a psychologist is done. You're finished. It's time to move on to something else. We're taking your PhD away from you because you're not going to need it now." And good luck. Thank you for your service and what you've done, and go do something new. Find a new career, find a new path in life. I don't think operators ever fully assimilate into civilian life, and I don't think that's a reasonable expectation for people to have. You're never going to truly become a civilian, and that has to be okay. But you do have to learn to live in the civilian world. There's a quote in my book that I just love. It's from an Army Special Forces soldier named Herb Thompson. And his recommendation is to treat, and this is in my book, this book right here, is treat the civilian world like a new indige. Approach it like you would a new indige. I just think that's very short and sweet and kind of brilliant. Okay, number 16, toxic exposure illnesses, respiratory illnesses, and cancers are a real concern. And these are concerns you guys have to be aware of and pay attention to for the rest of your life. I'm not an expert in these areas. The Hunter 7 Foundation, which was founded and started by Chelsea Simoni, who was an Army nurse. Go to their website and learn what they're doing, what they're recommending. Hunter 7 is the name of the foundation. And they're doing some important epidemiological work, research, looking at the rates of cancer by different types of units. And they've got recommendations and suggestions for screening and other strategies for paying attention. And then the existential concerns. I've got what was going to be a really short chapter in my book because I didn't know what even to say about it, but it turned into the longest chapter in my book on existential concerns. And I can't even begin to sort through these in our conversation today, but just to do it real quickly, guilt over things that one has done, guilt over things one hasn't done or didn't do, loss, grief, what's referred to sometimes as moral injury, which isn't necessarily a unique or separate category. Survivor's guilt. A big one is loss of tribe, loss of mission, loss of purpose. And that kind of is partly why I think the military civilian transition is so difficult. Because you have to swap out your identity somehow. Who am I now? What is my mission? Who is my tribe? Whenever we complete some phase of our life and we move on, whether that's graduating from school, finishing some advanced degree, career change, leaving the military, who are our friends? Who are the people we relate to and understand? And it's not on this list, but of course, suicide. A very common thing I hear is from guys is that they have lost 5 friends to suicide, 6, 7, 8 comrades to suicide or more. So to have a list of close comrades who are not here because they died by their own hand after coming home is common. I have not been able to find any true prevalence rates. Stop out of this. I don't think anybody knows the extent of this concern, but I think it's massive. And since I've been working with foundations, I often get I'll get a text or an email. I won't say every week, but maybe every other week saying we lost another one. And I get that a lot. And that's partly what's driving my efforts is we're just losing too many good people, people who are gone way too soon from us.
Well, you got an alliance in that one. It's definitely the ultimate tragedy. That's one of the main reasons why I got this going, and it's there are some answers. There are some things you can do before taking it to that level. Um, yeah, super sad. I'm so happy that you're here talking. Same with Kate last month and the other speakers we're going to have because there are a lot of options. It's actually pretty exciting. it's a pretty exciting time to be alive, I think, for treatment modalities and the lines of legal and not legal and what works and what doesn't work. I don't really care if it's legal or not legal. If the guy's not going to kill himself, then like let's try it. I don't care if he needs to eat like crushed up mug, whatever, dude. Just like stick around for a little bit longer
Yeah.
and we'll get you through it. There was a question when it came to the toxic exposures that I'm gonna drop it in right now was
Mhm.
are autoimmune issues in toxic exposures?
We don't really have a very good understanding, but my uneducated, I'm not an MD, but I would say yes. And part of what I think is going on, and this speaks to some other solutions for us, is that chronic systematic or systemic inflammation in the body is a huge part of the problem. So we know with TBI that it's neuroinflammation in the brain, in the neurons, and the glial cells. Modern life, we have a lot of inflammation in our bodies caused by the way we eat and by the lifestyle habits we have. And I mean, this is across all people. This is not specific to operators. We have we have a huge problem in our world, and you can see it when you just look around. The obesity, obesity is heavily driven by chronic inflammation. Chronic inflammation drives pretty much all of the chronic diseases, including depression. So our understanding of depression is evolving pretty significantly now. But the blast exposures and the chronic pain and the stress and the sleep deprivation, I think, are all massive drivers that push the inflammation up. So one of the lifestyle habits and things that I want to talk about here in a minute is very specifically ways to reduce that inflammation for you. Um, okay, so can I segue to treatment? Um, let's talk about treatment. And we need to be mindful that traumatic brain injury is not as simple as we used to think it was. Until about 10 years ago, pretty much all we thought was it's caused by impact forces. You get a blow to the head, whether that's falling off a horse, heading a soccer ball, being knocked unconscious um, with a punch or a blow to the head. That causes a concussion. Those concussions add up over time. The more concussions you have, the more bruising you have to your brain over time. So that's one form of brain injury, but there's other forms. So the big one is blast exposures. We now know that blast exposures cause a different form of injury to the brain. Blast exposures that shear through all the soft tissue in the body cause a pattern of scarring in the glial cells. These are the support cells. You have about 10 glial cells per neuron. They get scarred, they get damaged, injured and damaged over by blast waves. The more blast waves you've been around, um, the more that damage has accrued. And if you think back to, I mean, what are some of the things that do this? Of course, breaching, artillery, demolitions, and all, a lot of training in those things, obviously. Shoulder fired rockets, throwing hand grenades, even firing a rifle, especially a high caliber rifle. Those are microblasts. The more of those you have accrued over the course of your life, the more damage is there. We also have, I mean, we now have a better understanding of that oxygen deprivation, whether that's from being choked out or drowning. That's another form of of brain injury, and then just being exposed to things that you breathe also injures our brain. Toxic exposures in the environment can injure our brain, and so all of this just has a profound impact on our functioning. Okay, let's pivot and let's talk about the good news here. The good news, we have ideas, we have some solutions. I've seen many operators now really get their lives back. They're recovered, heavily recovered, functioning really well, happy in life, good relationships, successful careers on the civilian side, and so that's possible, and it's even probable if you learn and know what to look for. Modern medicine may not give you enough help, so you're going to have to educate your care providers. I'm not really as up on the foundation environment in Canada as I am in the US. For US operators, I can point them to a variety of different foundations that can provide different types of services. But okay, so what is the low-hanging fruit? Get a blood test, get your hormones checked, number one. Number two, get a sleep study. Well, let me talk about how we treat psychiatric disorders. We have okay treatments. Psychotherapy um, is worth exploring. If you can find the right therapist, it can be powerful. It can even be magic. If you can't find the right therapist, journaling is a pretty powerful self-treatment. Journaling, just spending 10 minutes a day writing down your thoughts or writing out your life story can even lead to insight and awareness of things. Typical mental health care is a mixture of psychotherapy and psychiatric medications. I am a fan of SSRIs, antidepressants. I recommend that you consider them if depression is at all part of your experience. But they aren't going to be a magical cure. And if you have doctors who are prescribing more than two psychiatric medications, it's time to kind of put a pause and go, okay, well, wait a minute. Where is this going? I'm not saying it's that you shouldn't be taking three or four medications. You might need them, and they might be useful and helpful, but they also could be a slippery slope into ending up with a lot of medications and being way over medicated. I think the norm for veterans in the US VA system is to be over medicated rather than under medicated. And that's a real problem. Okay, let's set the traditional care aside and let's talk about some things maybe you might not know of. Stellate ganglion block therapy. Stellate ganglion block therapy has been around 100 years. It's not a new treatment. It's safe and it's effective for what we want to affect. Neurology has been using it for 100 years, since the 1920s, to treat cluster headaches. About a decade ago, two neurologists at Fort Bragg noticed that when they treated soldiers, on the follow-up appointments, they came back and said, you know what, doc? Ever since that shot, I've been feeling really calm and relaxed. And my wife says I'm more present with the family and the kids, and I'm sleeping better. I'm not anxious at night. And there's these, that in and of itself is a wonderful way to begin a healing journey. Stellate ganglion block, I'll explain what it is. It's literally an injection, a single injection. It takes about half an hour. It's not an extensive procedure. It's very simple. It's very routine for the people who do this. They access the stellate ganglion, right? It's in the central nervous system, so it goes down our spinal column. They access it right around C6. And they inject a little medication in there, a little lidocaine, and you're done. You're good to go. You'll be feeling different within hours, maybe the next day. Really no side effects. There's almost no reason that somebody with a little anxiety and insomnia shouldn't get this. So I put this at the top of the list. The medication will wear off, so it's not a permanent cure, but the medication might last for 3 months, 6 months, even a year. And in the meantime, if you've been sleeping better, establishing some different habits, it's a very, very powerful treatment. Unfortunately, the mental health field doesn't really even seem to be aware of it. I had lunch today with a friend of mine who's a psychologist, and she'd never heard of it. It's just like, what are we doing here?
Why? Why? I'm gonna jump in. Like, why, if it's such a common thing, it hasn't just been
So
swept under the rug or something?
I don't know why, but to speculate, first of all, it's something that neurology does. So psychiatry and psychology and social work just aren't paying attention to what neurology does. That's probably literally part of it. It would be a disruptor, a business disruptor for the business model of mental health care. But it's a very effective treatment. You can find it in most cities if you just do an internet search for stellate ganglion block, or if you look at pain clinics. Pain clinics are one of the places you can get this treatment. Another treatment is ketamine infusion. Ketamine is a hallucinogenic medicine. It's been used by anesthesiologists and combat medics as a battlefield medicine, as a trauma surgery anesthetic. It's often used in conjunction with other anesthetics for injuries. It now, as of just very recently, has FDA approval in the US as an effective treatment for depression. And here's the other piece of this. Let me say more about what it is. So it's usually 4 to 8 sessions. You sit in a comfortable chair. A doctor puts an IV needle into your arm, and it's IV dripped into your body intravenously. And they run it for like an hour, sometimes less. Then they disconnect you. You sit in the chair for another hour or so until your head clears, and you go home. Usually it's 4 to 8 of those sessions. And you can put them close together. You could do 2 or 3 sessions in a week or more. So it's very effective, it's simple, and it's powerful. A lot of us are now thinking that the stellate ganglion and the ketamine done together in close proximity, like the same week or the same month, that they have a symbiotic effect on each other. And we think that each of these treatments stimulate neurogenerativity. So they're helping the growth, they're promoting the growth of neurons and dendrites and connections in the brain. So these are treatments that might actually be really effective for treating brain TBI.
Do you think that's like ganglion block kind of like calms that portion of your brain down, and then the ketamine allows you to get to that trauma, to just that little reptilian part of your brain is calmed down enough that you can approach those kind of subjects
Possibly,
theoretically? Hmm,
possibly,
interesting.
possibly. I helped an anesthesiologist write a short paper on the theory of this. And we did a single case study with that. So you can find that if you Google my name and Dr. Lipov, Lipov. That's something I can also share with Gordo if he likes. These are good treatments. They're just not widely offered. And I don't know why they're not widely offered. I think it's just a matter of old systems are not yet catching up to the most recent science. And ketamine is a hallucinogen. It's one of the hallucinogens. It's probably relative to others, a very mild hallucinogen. I will mention other psychedelics because I work with Vets Inc. and I work with the Mission Within and I work with Heroic Hearts. These are all foundations that are sending veterans and first responders to psychedelic medicine retreats in other countries. It's not legal in the US. I don't think these are legal in Canada, but you can go to Mexico, other countries south of Mexico, Jamaica, some of the other islands have programs. The one that I've seen, and this is anecdotal, but the one that I've seen that just kind of blows my mind because of the effects it's seen on my friends and guys I know really well, is a combination of ibogaine one night and 5-MeO DMT the next night. There seems to be something about that. We're just now starting to study it. Stanford they did a recent chart review study of only ibogaine, and it's jaw dropping, the benefits, the clinical benefits, not just to depression and anxiety and sleep, but also to cognitive functioning. And now they're doing it, a lot of places are doing fMRI studies where they're doing neuroimaging of the brain to look for literally the physiological brain changes that these treatments seem to be bringing about. I recommend these treatments myself to many people, but I also want to say we don't fully understand them. They're not without risk. And if you do seek out a psychedelic retreat, try to use one that involves a medical screening, that involves medical oversight. These are legal in Mexico. The Martin Polanco, who runs the Mission Within, has been running ibogaine clinics in Mexico for almost 20 years now. So the medicine he uses is well sourced, it's clean and pure, the dosage is specific and precise, and there's no fentanyl or other crap in there. What other treatments do I like?
Yeah,
There
you
are
don't want to mess
treatments.
around psychedelics. You want to make sure that it's top shelf, that you're going to the correct facility. I went down to Tijuana last January and did Ibogaine and 5-MeO at Trevor
Oh,
Miller's clinic. So just down the road from with you. What's the one you just named?
Mission Within.
Mission Within. Yeah, I've heard of that clinic, and then the same clinic I went to. And yeah,
Okay.
I can definitely attest to it. Trevor likes to say it like cleanses your lens. It cleanses your lens, your vision on your outlook on the world, your perspective on things.
Mhm.
Definitely takes addictions away. I stopped drinking for the first time in like my entire adult and young man life. And I stopped drinking for almost 4 months. I invited it back in, but the difference is that I don't it gave me a pause. It gave me enough like of a breath from my emotions that like was causing me to then drink or cause whatever reaction to build in the habits and the kindness to myself to be able to just be like, dude, chill. Like it's okay if you had a beer, all right. Like don't shame spiral. You're not a piece of shit. Blah blah blah. And I that was the biggest change for me with
Mhm.
ibogaine is that it let
Yeah.
me have some better reflections on things. So, but yes, always you have to have a full ECG or EKG screening before you go down. You're hooked up to a heart rate monitor the entire time. It's very serious. So,
And it's very different from, trying the mushrooms that your friend grows in his basement or a closet. That might be fine too in some cases, but you just don't know. So just be
yeah.
super careful there.
Yeah, it's always good to do it with your bros, but it's way better if it's controlled and doing psychedelics or any of that work without therapy or without any type of intention
Yes.
setting going into it is
Yes.
just getting high. So
Yeah. Hmm.
it's cool to see crazy stuff, but you should use these as the medicine that they're designed to. They can really do some beneficial work in your life.
Yeah.
Sorry for
No, that's exactly right. Thank you for making that point. It psychedelics are powerful, but they're also a tool. It's best to do them after you've had the stellate ganglion, after your hormones are starting to improve and get dialed in. Um, and it's best to use it with either with therapy or some form of journaling, some type of process where you're not just getting high. I usually recommend for at least a month before and at least a month after that you have a very clear plan of therapy or journaling and integration kind of conversations with yourself or hopefully some other experienced person.
I did cognitive processing therapy with it, and that was the first time I did like a formal program, not just like into stress, like
Mhm.
and doing that combined with the IBN and 5-MeO, like that is my hand on my heart where I'm like, okay, it's called psychedelic-assisted therapy for a reason,
For a reason.
and that I fully believe that that is the reason why I can like I'm hosting these events and talking about it instead of swimming in it, being like, oh, like what's happening? It gave me the pause to be able to look at it all and just turn it down, just turn down the frequency like just a little bit. It doesn't have to be the whole way. It's not a magic pill, but like if you can just get it down one or two percentages, then like it's a huge difference in your life.
Absolutely. All right. I know we only have a few minutes left, so I'm gonna go. There's some other things I want to mention. The chronic pain is such a massive problem. Tramadol and other opiates are just band-aids for it. They will help kind of paper it over, but they also have all kinds of other problems that you don't, long term, you don't want to live with. It's worth looking into regenerative medicine. Um, Regenerative medicine, sometimes referred to as functional medicine. These are clinics around. There's a lot of these clinics around, and I just started learning about them about 4 years ago. They use things that they inject into the joints that might be stem cells, exomes, peptides, NAD plus infusions. They've got a toolkit that they can use. You have to go find them. Our military medicine and our VA in the US does not seem to be very much aware of them. Thank you, Gordo. That's a good information there. That pain can be treated. Frequently, it can be really treated really, really well. And that's just a game changer. you clear that pain out of your body and you're going to feel like a different person. I do represent the variable resistance bands. I travel with mine. I'm on the road today. And I have my bands sitting over here. They're too far for me to reach, so I won't go grab them. But essentially they're large rubber bands that are flat, and the biggest ones are like that wide. I have one band I can barely budge when I push on it. So I don't use the biggest band very really at all. But I use all the other bands, and I get really good workouts. And like I said, I've bulked up a little bit, and my chronic joint pain is gone. TBI treatments. Speech pathology therapy is a very effective treatment for helping improve cognitive functioning. Another treatment is vestibular therapy. If you have disequilibrium, balance, vertigo symptoms, look for vestibular therapy. Vestibular therapy is sort of like physical therapy for your inner ear. It doesn't involve medications typically. It usually involves sitting in a type of chair that moves your body in different angles, and it reorients the little particles in your inner ear. It's kind of miraculous, actually. And I have family members who have vertigo, not from military service, but just vertigo, and they've gone through this treatment, and it was like a game changer. What else are some things? If you have a lot of GI distress, if you have a lot of chronic diarrhea, or bloating or constipation, get checked for parasites. You might have parasites. If you have, probably worth getting tested for heavy metals. You may have a lot of lead or mercury or other things that have gotten into your body over the years. Those are some things that you can do that, again, are fairly low-hanging fruit. I have a chapter in the book, and by the way, it's a short book. It's an airplane read. It's written not for people with, it's not written, I didn't write it for MDs and other scientists. I wrote it for you guys and your families. It's meant to be something you can read. You can read a chapter at a time. They're like short magazine articles on very specific topics, but there's a whole section in the book on the various treatments that are out there. And I haven't even gone through them all, won't have time to. But there's others that are worth knowing about. Lifestyle, and I want to say it's not all about what doctors can do for you, which is good, but it does mean you have to go and learn and do a little work here. Sleep hygiene is literally a skill. Learning the habits, learning the do's and the don'ts, the things that will help set you up for success with sleep. Incredibly good, strong research on the benefits of sleep hygiene. Most people don't pursue it because it sounds kind of fruity and goofy and like, oh, I can't sleep. And so what's the point of thinking about having a dark room and the temperature set at 68 degrees and that sort of thing? Sleep hygiene really works much better than people realize. There's a Navy SEAL named Rob Sweetman who has a program, 62 Romeo. And it's essentially taking sleep hygiene principles and making them relatable. And he does a lot of work with firefighters and operators. The other thing, and I mentioned this a few minutes ago about chronic systemic inflammation. And I want to just explain that a little bit because a lot of people don't know quite what I'm talking about. If you cut your finger, you have inflammation at that site of that injury, the wound. It turns red, it swells, it feels a little warm to the touch. That's our body's immune system coming in to protect and heal and prevent infection at the site of the wound. But we also can get this type of immune response, this immune inflammation throughout our body, and it could be in our bloodstream and it's everywhere. Every cell in our body is inflamed. I'm quite sure that a part of operator syndrome involves neuroinflammation and inflammation everywhere else. So what do we do about that? It's pretty straightforward in some ways. Cut out the crap. Stop eating and drinking stuff that's poison for you. So what does that mean? Essentially, it means eat whole foods. Don't eat fast food. Don't eat junk food. Don't eat sugar. I stopped eating desserts a few years ago. And for the most part, I still will on rare special occasions. What I found is Sugar tastes too sweet to me now. If I eat a cookie, it's like, ooh, it's too sweet. And other food tastes better since I stopped, putting sugar in everything. Eliminate sodas, all sodas, including artificially sweetened sodas. What else? Obviously, eat whole foods, fruits and vegetables, and real meat and real seafood. Um, Quality grains, quality oils. Eat butter. I eat a ton of butter. Eat olive oil. Olive oil is probably the healthiest oil we have. Get that stuff. Get that up in you. Minimizing drinking. Alcohol is an inflammatory. It's also a depressant. It also messes up our sleep. And then turmeric supplements. I recommend supplementation with turmeric, with omega-3s, which are good for the brain, and vitamin D. At a minimum, those are the three that probably all of us should be taking. Oh, and magnesium. Turmeric, which is anti-inflammatory. Omega-3, which is good for the brain. Vitamin D, which is good for everything and helps prevent depression. And then magnesium, which is important for many things, but it's also really good for sleep. So I take about 200 milligrams of magnesium an hour or two before bedtime. One last thing is the idea that um, uh, there's a couple other things that we now know reduce inflammation, and that's hot sauna and probably cold plunge. But there are medical randomized clinical trials of hot sauna bathing where they've used 3 sessions at 20 minutes apiece of hot sauna is massively anti-inflammatory and massively antidepressant. And if it's doing that, it's doing all kinds of other wonderful things for your health. Gordo, I'm going to pause and we can open it up for questions now.
Sounds good.
And maybe I talked much longer than I should have, but I'm happy to
Mm.
stick around for questions for a while or come back another time.
Okay, if you're down to stick around, then I would like to bang out the questions for them, and if people have more, then send them to me or email Chris directly through his website. We'll get you the answers. Um, I wish I wish I had a sauna. That is what I'm missing. My house is quite small, so I'm stuck with just the cold plunge, which is cool. I did a lot of like negative self-talk, like a month selection every day to myself, the first 10 seconds of getting into it, and then it's worth it. Um, can you speak to the epigenetic factors influencing operator syndrome? What does that mean?
Well, I can't really speak to it, but epigenetics refer to the way in which our environmental exposures change the manifestation of our genes. You can think of genes as a series of switches, and they can be switched on and off or put into a neutral position. That's oversimplifying, but that's about as smart as I am to do it. But what we know is your exposures, and this includes everything for all of us, the air we breathe, the water we drink, the people we have as our friends, everything, the parenting, everything affects the way our genes express themselves. So epigenetic changes, man, I couldn't even begin. I don't think there's even any research out there that could really answer that question with any specificity. But it's fair to assume the DNA you were born with and the DNA you started with at the time you enlisted or commissioned has since changed. There's no doubt about it.
I find it scary but exciting and relieving that they're finally finding out this news, but it's like, what do you mean they're finally finding out this news? And it's like, that's cool, they're finding out what's wrong with me. Wait, what does that mean? What's wrong with me? And what does that mean down here? It's it's good, but yeah, it can be a lot. It can be a lot.
I- I'm really hoping we can see a paradigm shift in the healthcare. Um, that we provide operators during their careers so that they can feel better, function better, have longer careers, and be less injured when the career is over. And I'm hoping that we can make that same paradigm shift for people after their career is over. And frankly, why not take a whole systems approach for all of us, everybody in our
Right.
society? Um,
Agreed. Agreed. I really hope with a lot of, I find the general population's apathy for soldiers is something that we should use to say, okay, we're willing to volunteer. Yes, send us, let us do this exotic medicines, etc. As soon as you let us do that in Canada or in America, then the FDA or Health Canada says, oh, well, what's the difference between that human and this human? And there
That's
isn't
happening.
much. So let's open the door. Let's
Yeah.
get it done.
And that's
Uh,
happening. That is happening. And to add on to that, so much of what I've learned in the last decade is I mean, some of it's from my reading and conversations with other healthcare professionals, but a lot of it is you guys going out and trying things and coming back and telling me about it. Wow, I went and did this and this and that, and this is how I feel now. A friend of mine, Dan Luna, came out to Hawaii with his family. I live in Hawaii, at the University of Hawaii. He came out and visited me at Christmas a few years ago and spent a week. He had just done the ibogaine 5-MeO a week before. Literally, I was with him 7 days later, and I was just like, "Wow, brother, what's going on? You are really, really different." It was notable, and it's now 4 years later, and he's maintained those gains. He's still benefit. I mean, those benefits didn't disappear. They're still there with him. He has a really happy life now. He and his wife love each other again. They stopped that disappeared for a while, but he's good with his wife. He's good with his mother, his kids. He's obtained a doctorate degree since then. I wouldn't have thought it possible for him to have done that prior to the ibogaine, as well as some of the other treatments that he did. Oh, he did hyperbaric oxygen therapy. That's another treatment that's
mm.
definitely worth looking into and knowing about.
There was a question, I'm going to jump back and forth. There was a question someone asked about breathing. Where's Emily? Oh boy. I think it was with breath holding. Familiar with IR or IR rest, or also known as integrative restoration in his work. Part two, has he come across active breath work in support of TBI and creating healing in the mind-body system?
I'm not quite sure I heard of any of the stuff on the first part of that question, but breath work, deep breathing, box breathing, yes, powerful, powerful intervention. You can use it. I mean, you have to practice it to be good at it. So that means doing it when you're not under extreme stress. But it works in the field, it works at home, it works when you're trying to sleep. And when I can't sleep, I use box breathing. I take one slow breath for about 4 seconds, hold it for about 4 seconds, exhale for about four, and then inhale for about four. So you kind of think of a box. Inhale, hold, exhale, hold, inhale. And I will start with 3 seconds, and then I go to four after a few rounds. Then I'll go up to 5 seconds at each side of the box. Usually by the time I get to seven, I'm sound asleep.
I use that to get myself into, I use it to sleep, but I also use it to start my meditation routine. I
Mhm.
only do like 7 minutes of meditation, but that's enough. That's enough for me. But I use the box breathing to get me into the point where I can find peace. But I find
Mhm.
peace through the breath, which is
Yeah.
it's not really strange. There was a bunch of questions about testosterone. What constitutes less low testosterone? What would be low testosterone in an average like operator group of males?
Well, medicine seems to define it. There seems to be two different standards. One is 300 and the other is 240. I had a tier one soldier a few years ago who I said, dude, you have low testosterone, and that's why you're not functioning, and that's why you're so depressed. I said, you got to go get this tested. He did. And he called me and said, well, the doc said it's in the normal range. And I was like, no, it's not. Go get the number. He came back a few days later and said, well, the number was 242. His doctor set the threshold at 240. It's like, what is wrong with these docs?
Right.
Fuck that guy. I don't know what was going on with that doc, but 242 is ridiculously low. 300 is low. And to just take these absolute numbers and say, well, you're 301 and that's normal for general population, so you're good, you're fine. That's bad medicine in my opinion. Now, low testosterone doesn't mean you need to have testosterone replacement therapy. Think of that as sort of the thing at the end of after you've tried some other things. So just sleeping better, reducing or eliminating alcohol, changing your lifestyle so that you're have a more anti-inflammatory lifestyle. All of those things are things that actually can help bring your testosterone back up. If they're not enough, then there's other medications that are still not quite um, that are still not quite testosterone replacement. Um, and then beyond that, there is testosterone replacement. So there's a lot of different things that can be done for hormones.
Okay. Um, do you see a correlation between operator syndrome slash PTS and irritable bowel syndrome?
Well, in some people, they definitely there is irritable IBS for many guys, or symptoms of IBS. But then my question always is it parasites? Got to rule that out. And checking for parasites has to be matched to the part of the world that you are in. So they have to test for if you were in the Sahel, there's a different parasite profile there than there is in most of the Middle East. So the testing has to be matched to the place where you were. But I have talked with guys that got tested and they were like, wow, I've been living for 10 years with a gut full of parasites that were then treated, and suddenly they felt and functioned very differently. IBS, I don't think we really know what IBS is. Probably stress contributes to it, pain contributes to it, insomnia and poor sleep probably don't help it.
Um, that would suck to have a parasite living inside you for 10 years. That scares me. Um, could you elaborate on what you would expect to be covered in a hormone panel? TSH, total AM testosterone, LH.
Uh-oh.
Does that make
Connectivity.
sense? Stuck with the what hormone panel?
Um, I froze up a moment a little bit there, so I actually didn't hear what you said. But let me answer what I think of as a hormone panel. I think usually you can just say to your doctor, I need a hormone panel, and that should be enough. But it should include testosterone, obviously, and there's oftentimes three different variables that they check there. You should look at estrogen. I got a surgeon who reached out to me a few years ago who said she's doing a lot of breast reduction surgeries in former Army Rangers and Special Forces because they have elevated estrogen. I think that's caused by the blast exposures. You should have the thyroid and human growth hormone checked. Ask for the panel, ask for the hormone panel.
What about non-psychedelic mushroom supplementation, like lion's mane? I've seen a bunch of that stuff.
Yeah, so there's a lot of things that are sometimes now called, I mean, for a while they were called superfoods, now they were calling them adaptogens. Um, I I'll tell you what I do myself, and there's not really good science here to really answer the question, but I eat a smoothie every day. I intermittent fast, so my first calories of the day are usually around noon. And in my smoothie, I put most of the obvious things, frozen berries, carrots, greens, walnuts, protein powders, usually a mixture of other nuts and seeds. Flaxseed is a good thing to add because that has a lot of omega-3. Walnuts have a lot of omega-3. And then I add some of these adaptogens. I add, and I'm a mixture of different things. Maca, I like maca root, which is good for your hormones, MACA. I put in, I mean, just, like a half a teaspoon. I put a little cinnamon in there. Cinnamon is really good for our digestive system. What else do I put in there? Beetroot powder. I mean, you could put almost anything that's sold as an adaptogen or a superfood. I do like mushroom extracts. So whether it's lion's mane, there's mixtures of where you might get 10 different mushrooms into one thing. I do use that. I do put a small, like a half a teaspoon of that into my shakes, into my smoothies in the morning. I, I couldn't tell you what the benefits of those specifically are, but that seems to be a good thing. I also eat a lot of mushrooms, just fresh mushrooms, and such, because I think mushrooms just are good for us. I don't even really clean the dirt off them anymore. I might wipe it off, but I think there's something good about getting the dirt, which is kind of weird.
I agree with the smoothie. I think it's like a secret superpower. I follow the exact same routine. I fast and then I break with a smoothie with a crazy amount of spinach. I put Brazil nuts in it for selenium. I don't know. I heard
Mhm.
we're all mentioning that. When you're talking about supplements, do you have favorite brands? Do you have ones that you would recommend or ones you'd stay away from?
That's really tough uh, for a variety of reasons. One is I don't know all the brands. It's hard to know what's good. I do like Elysium Health, and it's spelled with an E. Elysium, Elyseum, I think. Elysium Health. I think they're truly scientific. They test their things, and they have a product called Matter, Matter, that has high B vitamins and high omega 3s and a few other things. And they market it very specifically for brain health. Um, Maybe I'm a sucker, and I don't want to do the advertising for them, but I often recommend that supplement to guys.
Um, can you speak to the nuance between moral injuries and PTSD? Can they be interrelated and are the treatments different? I've heard you talk about moral injury before because I don't know if you like the language of it. Um, I think I was more in the camp of like I kind of like the idea of it, but it makes me very interested to hear your opinion on it.
Well, let me start with this. I think there's no question that existential concerns are a real issue, a real problem. I have an entire chapter, and it's a long chapter in my book. I think it's the longest chapter, and it was the hardest chapter for me to write. I try to provide both a historical context for the types of ways in which people are affected by war, morally, spiritually. Um, I go through a little bit of the history and the philosophy and thinking of the just war philosophy. And, but kind of when you come out the other side of a career, there are so many ways in which you may have been morally injured or existentially injured or bothered that it's not really easy just to sum it up in one neat, concise little, sentence. Is that separate from PTSD? Yes. PTSD is an anxiety disorder. Existential issues, spiritual issues, I think and they commonly go together, but I think the existential issues are very different and are kind of a unique aspect of being a warrior.
Because they're so personal to there's no I kind of treat trauma like a scale, whereas okay, I went to war, all this stuff happened, and I'm hurt X amount, and a person who got in a car crash is still hurt X amount. Maybe interior to them, they feel the same way that I feel. It's the same anxiety, blah 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 blah. But our optics are like, well, that person got in a car crash, and this is what happened to him. Is that where they're
They may
so
not
different on the inside of the existential question?
Yeah, they may not be thinking, I mean, they may not have those thoughts of I was trained to do some things in the military that I was taught were wrong as a child. The Ten
Mm.
Commandments, for example. I don't know how many of the Ten Commandments you might have crossed at some point in a military career, but I think you have hard choices to make, and it's impossible always to make the right choice in a split second. And frequently, it's impossible to know what the right choice is, even with hindsight. There may not be a good choice. Do you go left or you go right? And either way, there's bad things that happen. Some examples of things that I hear a lot are I was supposed to be on this mission. I wasn't able to go. Somebody else went in my place, and it, it didn't go well. They died, and it should have been me. That's something I hear a lot. Um, the grief over comrades lost, the grief over, or the existential sense of, man, I had all these comrades I lost, and I never cried. I never grieved, and that brings a pain and a reaction. Um, the horror of killing, occasionally I hear about that. Fairly often I talk with guys about the thrill of killing and how
Hmm.
much they enjoyed it, which is something that we don't talk about in typical therapy sessions. Um, but the literal pleasure of battle, of combat, hand to hand combat, killing a man with a knife or a club of some sort. I actually hear that quite a bit, and the way it comes out is sort of their shame. It's like a secret shame. Guys kind of whisper it to me. I actually enjoyed it, and it's like, yeah, I know, it's okay. That's common, and just to hear that it's common often is somewhat helpful to guys. I think I have a quote or two in my book. Oh, can I just say, in the book, I wrote this book, but I had a lot of help. There are the voices of over 40 different operators represented. So throughout the book, there's quotes, direct quotes, with names and attributions. I think I have about 10 or 12 spouses of operators, and then I've got a handful of other medical scientists and providers who work with the community. So it isn't just my words, it's a lot of collective wisdom that I've collected and put together. Um, the death of children, that's hard. That's maybe one of the worst things. Being present or holding a child when they die, or maybe even being the cause of a child's death, or feeling like one was the cause of a child's death. Those are oftentimes issues that really can haunt guys.
Across
And
the
so
threshold.
much of this, yeah, so much of this is hard to process in traditional psychotherapy. That just may not be the place where you can talk about it and begin to um, figure out what those demons mean for you and what to do with them. I think that's one of the values of psychedelic medicine. I think that's one of the values of journaling, and sometimes it's the value of peer support services where people can come together and talk with their peers, others that experience the same or similar kinds of training and deployments.
I have faith. I think we're heading in the right direction. These kind of conversations are what's changing, what's pushing the conversation to a different place. Um,
Yeah.
with it's someone had a good question about adverse childhood events and what kind of correlation that is to operator syndrome. And I've heard that spoken before on Sean Ryan's show. I
Mhm.
think it was another neurophysiologist that was on it, but it's the thing that we don't talk about is that like, what's this person bringing to the
Yeah.
military before
Yeah.
all of a sudden
Yeah.
they get into it? And
Yep.
it's just like,
Yep.
well,
Yep. I talk about that in the book too. This is something I and many of my um, of the other care providers have noticed, that a lot of guys come into special operations with adverse childhoods.
hmm,
Oftentimes that includes physical abuse, sexual abuse, absent fathers, neglect. Um, Friend of mine who's currently active has an extensive history of gang violence. Uh, Prior to age 16, he was homeless. He was on the streets much of his childhood. He was running with gangs as a way of survival. And then he enlisted in the Navy and became a Navy SEAL. And so, we think of childhood trauma or adverse events experiences as being things that damage us and break us. They don't always do that. Some people become hardier from that. Some people get that chip on their shoulder and was like, okay, the world didn't give me a good start, but now I'm gonna go turn some things around and do some amazing things. Um, this is not really a fair analogy, but I think of Tom Brady, one of the greatest NFL quarterbacks ever, who was drafted, I think, in the sixth round. And so he came into the NFL with zero expectations of being any good. And he had a chip on his shoulder, and he played his entire career with that chip on his shoulder. Um, not a very good analogy, but sort of a
No, I believe it. I totally believe
sports
it.
analogy.
I think we need to have that analogy as a veteran leaving the military and like take it on as a challenge instead of being like, oh, I'm a victim and or oh, I'm a wounded soldier. It's like
100%.
it's exciting. It's just like having your own indige force. It literally is that. Like you can create your own, you can create so much success. You can create whatever you want in the civilian world. We're so constricted in the military, even in the special forces in a flat organization. It's like well, until you get out and you realize like, oh wow, oh, okay, cool, I can do this. And it is scary to take that bet on yourself that every day
Mhm.
you get to rewrite your story and I find it just as exciting. It's when the light goes green every morning, it's the same thing as jumping on the airplane. Like, all right, let's go. Like,
Yeah,
what does it have for us today?
yeah.
Um, I think that's all the questions. If I missed any, there was quite a few, almost 55 or so. Those were comments included. If there were some I missed, you guys can send them over to me, and I'll pop them over to Dr. Chris, and he can let us know his answers to them. Was there anything else you wanted to discuss before you left, other than your book? I know you can get it on Amazon. You can click on the
Yeah,
hyperlink for your website.
Amazon is probably the place to go.
Okay.
Um, I learned my publisher doesn't ship outside of the US, which is I don't know why, but so I think Amazon is the way to go.
Okay. I
Yeah,
got mine.
let me share one sort of last point, which is, um, and I try to make this in a variety of ways. What we are talking about here are injuries. None of this is shameful. Injuries in the service to your country, to our society, and you're injured. And we're talking about injuries literally at the physiological level, molecular level, cellular level. These are injuries. And if you're injured, which you are, go get help, get that recovery, get that healing, because it's there to be found. Get after it. Don't accept that this is that the pain and suffering and the functional impairments. Don't accept that those are going to be there forever and that there's nothing that can be done about them. I want to leave with a message of hope.
I don't want to water it down any more than that by my voice. So I I totally agree with you. There's more. Look at all the stuff we just talked about, and this is all very new. So, all
Mhm.
right, perfect. If you need anything from me or any of our audiences, you have questions, ask them to me. I'll put them out to the Canadian world, and we can get you some answers on that. Thank you so much for taking the time this evening and going over the our time limit. I can't thank you enough from a personal standpoint, not only to figure out what's going on with old Gordo, but then to pass that on to the bigger community. Thank you so much. I very much appreciate it.
Well, let me turn that back on you and say I appreciate not just what you guys have done, but how, the sacrifices you've made, and truly a big honor for me to be here tonight. So thank you for having me. I hope to get up to Ottawa
Yeah,
one of
I
these days.
know. Let's go. Get on your guys' chain of command. If you guys want to see, you guys want to have a little mental health retreat or a night gala function thing where we can get some guest speakers to come up, like Mr. Dr. Chris here, then let's get it done. Again, thank you so much. Buy his book. Thank you everyone for the support, and I'll see you guys next month. See you, Chris.
Awesome.